Good morning, good afternoon, and good evening to everyone attending this International Headache Society webinar. And it's a premiere because we are now starting the Physiotherapy Special Interest Group. I'm just hosting this. My name is Henrik Schütz. I'm chair of the Education Committee together with Marcio Nathan. And I really look forward to this. I think this is such a great and important initiative. And we have 4 experts among us, and we'll have a presentation from each one of them. We will try to make this as interactive as possible, so you'll have the chance to ask questions. And I really recommend that if you have questions, then write it in the Q&A box that you see below, and then we'll make sure to answer them at the end after the presentations. So now I leave it to Professor Kerstin Luedtke from Lübeck in Germany. Welcome.
Thank you, Henrik. Thank you for organizing this, and thank you for having us. We are all a little excited because this is the kick-off meeting of our new special interest group, Physiotherapy, as you said, and it's really nice to see all these names and all these messages popping in. I have to close this because otherwise I'd be really distracted reading all the messages from all over the world. The plan for today is to have an introduction of our group. This will be very brief, so we'd like to tell you what the 4 of us have been planning, what we are thinking, and why this group is needed. You'll also see some of the research that each of one has been doing from our own clinical and research perspective. So there's going to be a few slides from each of us in the room, informing you about our backgrounds and trying to, well, maybe include you as much as possible. We cannot see you. The only thing we can see is your question and answers, and we can see what you're writing in the chat. But unfortunately, this is all what we can do interactive. But what we have done is we have prepared a Mentimeter. So if you've got your smartphone nearby, that would be useful, because then we can see who's out there, where you're from, and what you're expecting from us, because this group is not only the 4 of us. This group is going to be hopefully a big international group, and we would like to respond to as many wishes and desires that you are having in the near and further future. I'm going to start with a few slides. So I'm going to share my screen and show you what we have prepared. So this is the introduction. You probably, or a lot of you will probably know the 4 of us. We are from different ends of the world, and we really, really like it. The thing we don't like about this is that one of us has to always stay awake late and rise early in the morning if the 4 of us want to meet. So last night, it was me who had to stay up late, and it was Gwen and Zhiqi who had to get up really early. Today it's Australia who has to stay up late, so to your end. And I know that all of you are from all the different parts in the world, so thank you very much for taking this time, no matter what time of the day it is, to join us. And I actually would love to see all those little dots of you popping up here and seeing where on this map you are from. What are our aims? We have defined some aims. We had to define some aims to actually apply to be part of the IHS. And what we thought was really important is to define the status quo. So where are we at the moment in terms of different type of headache clinically and research-wise? Following from this, we think it's really important to provide education from our group to everybody who is interested by producing those online events like this one, but also maybe being able to have something like a standard of education for the universities who are providing undergraduate physiotherapy training, but also providing and influencing postgraduate training on headaches. We would like to be a forum for all of you, a forum with your aims and a place where discussion can take place, on and around the topic of all types of headaches and physiotherapy. And obviously, the ultimate aim is to improve clinical practice for those patients who are suffering from different types of headaches. So contributing to the information that's provided about the burden of headache is one of our aims, and to facilitate evidence-informed practice all over the world. Make physiotherapy for headache patients accessible. So we've got this little Mentimeter thing. This is the moment where we can see whether modern technology works. Please take out your smartphone, switch your camera on, and hopefully you can scan this QR code. I'm gonna have to get out of this presentation and go onto the Mentimeter once you have scanned the code. It's gonna be shown again, I think, I hope. Giving you some time to all get into Mentimeter. Funny that I can't see you, so I hope this works. And then I'll be sharing the screen with you, and you can respond to some of the questions we've come up with. These are really just to get to know you. Let me check where I am. Find the PowerPoint. Here we go. So what I would like to do is present this. Now, so you should be seeing a question on your Mentimeter. Oh, I can see people responding. That's really nice. If you haven't logged on, you can also go onto the website, mentimeter.com, and you can still join us using the code that you see at the top of this page. It's a number. Okay, there's lots of thumbs up, which is good. More thumbs up. Right, you've done it. So we've got a lot of Europe, probably because it is a very pleasant time of the day. But as we saw in the chat, there's a lot of people who are still awake in Australia. Very nice. More questions to you. So who are you? What are your professions? Are you physiotherapists, neurologists, nurses? Are you here as a patient maybe, or psychologist, or other? Other is a big secret. You don't have to tell us. And again, here's the code again, or the number if you still want to join in. It's not a test, doesn't hurt. We're just being a bit curious. So lots and lots of physios. Great. Thank you for playing along with us. And in your profession, are you mainly working as a clinician or as a researcher, but you can select more than one if you've got maybe 2 part-time jobs? There's some students here. That's really nice. Lots of clinicians, some researchers and lecturers. Fantastic. And again, lots of thumbs up. Don't know how you do it as they keep going up. Right. Next question. And now it's getting a little bit more to the bottom of things. So why are you interested? When you heard that there's a special interest group in headache, what did you think? Why did it sound interesting to you? It's a little bit harder. You have to actually provide words. Research and treatment. Career, okay, nice. Best practice, I like. There's lots of responses who are around connection, collaboration, discussion, community. So something that could be described as joining forces, international collaboration. Starting to get a bit too small to read, but we will keep this and use it as our resource of what we should be doing next. The bigger the words, the more times you have written this word. More best practice, more education, that's interesting. Community, advocacy. Yeah, great. Nice. Oh, this is really nice. I'm going to print this and put it up somewhere, I think. More responses coming. And this is the last slide, another one where we need a little bit of brains. So what do you think we can offer? So what would you like this group to offer to you personally as a researcher, as a clinician, as whoever you came as today? But you can also react to the answers that other participants provided if you agree with them. So you can sort of vote them up or down. And I don't think down, up. I think you can vote them. See whether there's any brave people who provide some answers. What can we offer? Probably something along the same lines as before. I think we asked a difficult question.
No, I think there are responses are hidden. Can you?
Are they? Okay.
Yeah.
Oh, okay. That's even even more interesting. So we've got some secrets. I'll show you later. But leave it open.
You've got to press see the instruction at the bottom?
No, I can't see any instructions just now. What do I need to do?
Press H, I think, to show responses.
H. Oh, magic. Thank you very much, Gwen. Right, so we do have a lot of exchange, network, collaboration. Fantastic. What else have we got? Review the classification. What would you like this group to offer to you? Europe, that's an interesting one. Don't really know, maybe you can put in the chat what you mean, because I find it difficult to offer Europe to you. Share data, inform, help physios, be a central resource, treatment options, like-minded group of therapists. Yeah, totally agree. Good points. I think we've got a long to-do list for the next month. So we're gonna keep this and look at it and see that we can tick off lots of those points that you have suggested. Great, thank you very much. So we're stopping this. Now we know who you are. And I would like to ask Gwen Jull from Australia. I think you all know her. Very difficult to introduce you, Gwen, with all the fantastic things you've done. Expert on cervicogenic headache. You were my superhero when I was an undergraduate student, and now we are in this group together. So it's really nice to see what you are saying about cervicogenic headaches.
Thanks, Kerstin. So as you all know, that cervicogenic headache is classified as a secondary headache, secondary to a cervical musculoskeletal disorder. Now, we actually have got quite good evidence of effectiveness of multimodal programs of education, manual therapy, and therapeutic exercise. And that comes in particular from 3 large trials that looked at both short and long-term follow-up. So you could ask, if we have got evidence of efficacy, why is this physiotherapy special interest group needed? Well, I think 2 major things to start with, and that's to work collaboratively with the International Headache Society, firstly, to enhance the physical classification criteria for cervicogenic headache for differential diagnosis, and also to expand the understanding of the cervical disorder so that we can better direct patient-centred care. So just taking the first point about enhancing the physical diagnostic criteria, currently the physical criteria are reduced range of movement with neck pain and diagnostic blocks. But as we all know, range of movement is highly variable within and between sexes and age groups, and we've got no individual cutoff to sort of say, well, that is a pathological movement restriction. And we also know that cervical range of movement can be reduced in migraine and tension type headache. So just having a criteria of range of movement doesn't really help with differential diagnosis. And then in relation to diagnostic blocks, they are invasive, so they're not suitable for the primary clinical diagnosis of joint dysfunction. So what can we offer? We've got evidence that cervical movement tests and manual examination can identify symptomatic joint dysfunction. So the diagnostic movement tests are the flexion rotation test for a C1-2 joint lesion, and also the segmental extension rotation test, which can be accurate for the zygapophyseal joints. And we've got 3 studies that have validated not just the movement test, but the movement test plus manual examination to identify symptomatic joint dysfunction. And they've been validated against the reference standard of diagnostic blocks. Now, a further point is that musculoskeletal disorders present with a predictable pattern of physical changes. So, for example, if I just found some weakness in the gluteals, that doesn't tell me too much about anything as far as diagnostics are concerned. But if that's associated with restricted movement, for example, restricted abduction, internal rotation, extension of the hip, and I've got joint signs, and I've got that muscle weakness, put those 3 signs together, and I've got a reasonably good clinical diagnosis of osteoarthritis of the hip. Now, we have found that it's exactly the same with cervical dysfunction in cervicogenic headache. We've got that same familiar pattern, and we've shown that restricted range of motion, the joint signs in the upper cervical area, and muscle weakness, they collectively can identify cervicogenic headache from other headache forms. Furthermore, this predictable pattern has been validated against controlled diagnostic blocks. So as far as the Physiotherapy Special Interest Group, I think what I'd like to see us do is encourage further validation studies internationally, and then advocate for inclusion of specific movement, manual and muscle test outcomes to enrich the classification criteria for cervicogenic headache, and also be a resource for the acquisition of physical examination skills, so an education role as well. And then the second thing was to look at trying to enhance our patient care. In our trial of cervicogenic headache, which we did several years ago, we had 200 subjects with cervicogenic headache. So not only did they have headache and neck dysfunction, but they also complained of lightheadedness and blurred vision. So in the context of a cervical musculoskeletal disorder, there are symptoms of dysfunction in cervical-related sensory motor control. Now, people in the RCTs with these symptoms, we found that they didn't respond as well to the manipulative therapy and therapeutic exercise as did the people without these symptoms. And we offered no training of sensory motor control in that clinical trial. But in recent years, we've also provided evidence that the outcomes are superior if this impaired sensory motor dysfunction is actually addressed. So again, as I see it, one of the roles why the special group is needed is to encourage and facilitate further research into the prevalence of sensory motor dysfunction in cervicogenic headache, and also towards the development of enhanced patient-specific management programs. And thinking about randomized controlled trials, there have been several RCTs, I've mentioned 3, but there's been an awful lot more published on various techniques of management for cervicogenic headache. And I think that we've got to remember that RCTs are expensive and time-consuming to conduct. And many of the recent RCTs are underpowered, and the long-term follow-up is rare. So looking forward, we've always got to remember that RCTs inform systematic reviews and clinical practice guidelines. And if we have poor quality trials, that actually downplays or produces low or very low quality evidence, which is not good. So I think that our trial designs must be flawless, and we must ensure that the most appropriate interventions and patient-specific interventions are tested. So finally, I see one of the roles of this group as a forum for discussion and advice for future RCTs, particularly for cervicogenic headache. And now I'd like to hand back to Kerstin, who's going to talk about migraine and neck pain.
Yeah, thank you very much, Gwen. Really important topic. And I will follow on with a different type of headache. So now we're talking about migraine, about a primary headache. And if you've got questions regarding Gwen's talk, please put your questions into the question and answer box so we can then discuss all questions at the end. So about the neck, it's indeed, migraine patients have neck pain, and they've got lots and lots of neck pain. And the more chronic a migraine is, so the more headache days per month a person has, the higher will be the incidence of neck pain. And chronic migraine, it's 87% of patients who reported neck pain. And thank you, Henrik, for this really nice systematic review and meta-analysis, which I'm probably citing in every manuscript I'm submitting anywhere. We were really intrigued by this because neck pain is not necessarily the same as neck dysfunction. So you can have a pain without a dysfunction, and you might even have a dysfunction like a limited range of movement, which doesn't hurt. So what we wanted to find out is whether patients with migraine also have more detectable by physiotherapists dysfunctions in the neck. And for this, we developed a Delphi study where there's a lot of the people who contributed to this are online. I saw your names, so nice to see you again. And this group of people agreed on a set of tests as a minimum standard to evaluate musculoskeletal structures in patients with different types of headache. And we applied this test or this battery of tests to 170 migraine patients and looked at whether there was anything detectable. And the ones where you can see the green check sign, those were the ones where migraine patients were significantly more impaired than persons without any headaches. So yes, migraine patients have also neck dysfunction. It's really important to remember that migraine is a cycling disease. It's different from other diseases which are more sort of more tonic pain or more constant pain. Migraine comes and goes, and you can distinguish phases, the ictal phase where there's the headache, but there might also be other symptoms like photophobia or nausea and vomiting. And then there's an interictal phase where patients with migraine are no different than other people, or you have to actually look really, really hard to find differences between interictal migraine patients and people without headaches. This is also important to remember when we as physiotherapists are doing a physical examination, because a lot of our tests, especially the manual test, like joint palpation or trigger points, rely on the patient report of symptoms of pain. And if there's fluctuations in the sensitivity of tissues, then this report will change throughout those different cycles. So I think it's an important message to provide to you today, one of those few messages that I'm allowed to provide in those few minutes, but it's really important to know where within the migraine cycle people are while you're assessing them. It's also important to remember that it's not only cycling, but migraine is a primary headache. Primary meaning that the headache symptom are the disease itself. There's no headache because of some other disease or some other joint, whatever issue or muscle issue. The migraine is the disease and the symptom in one. And we know this from lots of studies. This is from my old work group in Hamburg, and we know this from lots of imaging studies. In this case, patients have been imaged on 31 days, each and every day, providing different stimuli. And even before the patients themselves knew that they were about to get a migraine attack, the hypothalamus, so a part deep in their brain, already knew that the headache would be coming. So the hypothalamus started to be more sensitive towards any sort of stimulation towards a migraine attack, even if the patient was unaware that the migraine would be starting within the next 48 hours. Interestingly, and maybe one of the reasons why you're here, possibly, is that migraine is, or physiotherapy is not an evidence-based treatment for migraine patients. So in most of the guidelines, certainly in the German ones, which are probably the worst on this planet, but in most of the guidelines, physiotherapy is not specifically recommended for the treatment of migraine patients. Then again, migraine might just be some other chronic pain disease. So migraine has and shares some of the same features that other chronic pain diseases show in like chronic low back pain patients or chronic neck pain patients. And one of those is data provided by one of my doctoral researchers and colleagues, Débora Zhiqi. He investigated offset analgesia as a proxy to measure the capacity of the pain inhibiting system. So pain inhibition is impaired in patients with migraine. And what we can see here is the left two boxes show that this is much larger in the trigeminal system. So the impairment is larger in the trigeminal system than it is on the arm. So measuring the forehead will show worse inhibition than measuring the forearm. There's other features which are similar to chronic pain diseases, such as a larger 2-point discrimination threshold when measured in the neck, and also worse reaction times and more mistakes when judging right and left sides of the head or the face. Furthermore, when providing pain neuroscience education, which we know is an evidence-based treatment for chronic pain, then migraine patients will benefit from this, and they will benefit more than just when they are receiving physiotherapy treatment. So if you are providing education on top of physiotherapy, it will increase the effectiveness of the physiotherapy treatment. So combining these few examples of studies that we and other people have done in the past, we're still at a very preliminary stage of physiotherapy research for migraine. And I know that there's more to come from Zhiqi and Débora, who are also interested in migraine patients. But at this point, I think it's really important to look a little bit deeper, because these are only preliminary findings. There's very limited amounts of work groups that I'm aware of that are focusing research activities on physiotherapy and migraine. So we need a lot of validation of those preliminary studies. We need a lot of multi-center investigations, and hopefully that'll be international. So hopefully you people out there are willing to do stuff with us together, so we can have data sets that are more diverse, more international, and from different clinicians and not one person in one laboratory setting. We do need treatment studies, definitely, to inform the guidelines so that physiotherapy will show up in future guidelines. We need to talk more about our patients. So what are their views? What do they need? We've got lots of difficulties in physiotherapy research with shaman control groups. So maybe you've got some ideas how to do this better than it's been done before. And annoyingly, we need more longitudinal designs. I know nobody wants to do those studies. They take time. We lose patients on the way, and they are not as easy to do as basic science stuff done on healthy young students. But it'll be worthwhile because it will ultimately improve how we can train physiotherapists and that we can provide effective physiotherapy management on top of, obviously, the really important medical management for migraine patients. And this is why I think this group is needed for patients with migraine. But I know that Zhiqi has got additional and more in-depth insights on migraine. So please listen to Zhiqi Liang from the University of Queensland.
Thanks, Kerstin. I'll share my slides now. So here we go. So our research group has been recently more focused at looking at the mechanisms underlying neck pain in headache with the aim of subgrouping patients for better targeted management. So looking at how we can approach intervention from a slightly different perspective to see if there's better outcomes. So this is working on the premise that neck pain and headache is not homogeneous. And we all are familiar with this. We know that the neurophysiological mechanisms within the trigeminal cervical nucleus means that there can be bidirectional referral of pain and sensitization between the head and the upper cervical spine. So what this means is that firstly, the neck, as what Kerstin has already mentioned, is that the neck can become very sensitized in some headache patients. And we can see this, especially in migraine. And there's a lot of examples in the literature where, it's been reported that neck exercises and manual therapy treatments can trigger a migraine attack. And I'm sure a lot of you have noticed this in the clinic as well, that, in some patients, we can easily reproduce their headache when we palpate the upper cervical spine. But those neurophysiological mechanisms also mean that there are two possible sources of neck pain in headache. And one would be, someone having local cervical nociception, such as a local musculoskeletal disorder. But, neck pain and headache can also be a symptom of headache that's entirely referred from migraine, for example. So then what this means is that there are many possible presentations of neck pain. And if we use migraine as an example here again, you could have someone with a neck disorder, so they have a local neck pain and a neck musculoskeletal disorder that just simply coexists and is unrelated to the migraine. And then in some patients, you probably think that the neck disorder that they have could be contributing to the migraine. The opposite could be also true, that someone, as what Kerstin has already mentioned, this being a primary headache and neck pain could be just entirely referred from the migraine itself, and there could be absolutely nothing wrong with the neck at all. And of course, it could be a combination of both, that someone's neck pain can be a combination of both something that's, nociceptive due to a musculoskeletal disorder in the neck, but also referred from the headache, the migraine itself. And this is basically what we found in our clinical studies, that about 60% of our research cohort of more than 100 migraine participants, 60%, despite having neck pain, had nothing wrong with their necks. But the other 40% had cervical musculoskeletal dysfunction, and this was dysfunction that was similar to what Gwen was talking about before, where they didn't just have a muscle impairments, they didn't just have range of motion impairments, they had that group of impairments of movement, joint, muscle impairments that you typically expect in a painful joint disorder. So what does this mean? Could it mean that neck treatments that target local musculoskeletal dysfunction of the neck would be more appropriate or have better outcomes for those patients that we can actually identify this group of musculoskeletal impairments in? And this is possibly something that as a special interest group, we can all explore together. Now, the other thing that we've also found is that some migraine participants are very symptomatic during physical examination. And Kerstin mentioned that already, that, around the ictal phase, pre-ictal and post-ictal, patients are very sensitized. What we found in our study is that even in the interictal phase, there's a group of people who are sensitized in the neck as well, even interictally. And when you do physical examination, they will often report symptoms, even with low load tests like the craniocervical flexion test. And many of these patients, despite having symptoms during these tests, actually had normal cervical function. So what this means is that skilled physical examination is key. And again, this is possibly something that we should explore as a special interest group in education for the profession to have good ways of examining, assessing, and treating patients. So finally, I just want to leave it here that, thinking of how neck pain can present differently, and it can be complicated by sensitization from the headache disorder itself. There are lots of things that I think we can explore as a special interest group going forwards into understanding these different presentations a bit more and finding out what are the better ways of providing targeted management based on these different presentations. So I'll stop there, and I would like to hand over now to Débora, who's going to tell us a bit more about her research. She's got a long history of research in migraine and headache. So over to you, Débora.
Thank you. I will share my presentation. Hello. Why do you need a special group in physiotherapy? I hope everyone has been convinced that, but I will show a little more about our work in Brazil and how physiotherapy can help the multidisciplinary team in treating headaches. It's why we are here. We are here because our patients, and as you know, migraine, it's a multisensory disorder and not just a headache. I have been working with migraine patients since at least 2008, when I did my postdoctoral research with Dr. Lipton and Dr. Bigal.
Sorry, Débora. Sorry, Débora. We cannot see your slides.
Oh? Ah, yes. No, I'm very excited. Sorry. Right. Okay. And now, are you seeing my screen?
Yes, it's perfect.
Together again. Yes, I just say the same in my introduction. And now I was talking about my research working in Brazil. I have been working with Dr. Lipton and Dr. Bigal in 2008 at Montefiore Headache Center in New York. And my research on migraine has two main directions. The first one is the musculoskeletal disorders associated with neck pain, temporomandibular disorders, and orofacial pain. And in our data from Brazil, we have observed similar musculoskeletal alterations in migraine patients. Our findings are aligning with the results that Kerstin shared with us previously. These alterations are summarized in this paper, and we see in these data. Migraine patients present reduced cervical range of motion, lower muscular performance, and higher sensitization. We know that the higher frequency of migraine is related to worse upper cervical range of motion, measured by the flexion rotation test, and greater neck extensor activity during the craniocervical flexion test, and greater neck pain disability. As the frequency of migraine increases, cervical muscular endurance and strain in the cervical extensor muscles decreases. And another direction of our research is the group with balance alterations. We study imbalance, vertigo, and dizziness in this special group. This group is less investigated, but they are also likely to benefit from physical therapy intervention. The changes in balance are not limited to quiet standing. These patients also affect daily activities such as walking, climbing stairs, overcoming obstacles, and sitting and standing. These patients show reduced limits of stability and motor control reactions following external perturbation. They are also influenced by psychosocial factors and are associated with increased risk of falls. These imbalance alterations have been further linked to aura and chronic migraine. Interestingly, the presence of vestibular symptoms or vestibular migraine diagnosis does not seem to influence balance in migraine patients. Despite all the results we have found, and considering that migraine is a multisensory disorder, a question remains. What are the validated measures of sensory amplification that can serve as biomarkers for migraine progressions? To answer this question, we are collaborating with Professor Brennan and Dr. Cortez from the University of Utah. We have received the approval from the NIH for a huge project to study this issue in an interdisciplinary collaboration among doctors and physiotherapists. To address this research question, we will conduct a cohort study to investigate the factors involved in the chronification process of migraine. We have already shown an association with the chronification process with center outcomes, but this was done through a cross-sectional study in our group, focusing in neck pain, balance, dizziness, and allodynia. Now, in this cohort study, we will investigate other factors involved, including those that reflect the sensory amplification of migraine, such as photophobia, phonophobia, osmophobia, and nausea. We expect that the resulting biomarkers will advance the field of migraine research by providing quantitative tools for predicting disease progression. Furthermore, our missions is to determine whether physiotherapy intervention can help patients with migraine. To that end, we have conducted some randomized clinical trial testing the effect of different physiotherapy intervention, including in this RCT, the manual therapy, specific exercising, and now we finish RCT using multimodal therapy and neuroscience education. And now, in collaboration with Antwerp University in Belgium, we are developing a new RCT to study the effects of an aerobic exercise program on the level of sensitization in migraine patients. In addition to conducting research in this area, we have activities to ensure that this knowledge is implemented in clinical practice. We are part of a multidisciplinary team at the Headache Outpatient Clinic at our tertiary university hospital. And we also have a rehabilitation hospital when we run physiotherapy clinic that treats patients with headache, neck pain, and temporomandibular disorders. Here, we have students at various levels from undergraduate students to PhD students. They treat patients and enhance their clinical skills under my supervision and by highly specialized doctors. In addition, we offer a postgraduate specialization program in musculoskeletal disorders, accredited by International Federation of Manual and Musculoskeletal Physical Therapists, or IFONT, and we receive 12 students per year. These students are training according to the latest evidence to treat patients with headache and temporomandibular disorders. My research group has already training over than 60 students, including, how can I say, the undergraduate student in scientific initiation program, as well master's and PhD and postdoctoral student. Actually, this is my research group, and it's a great pleasure to be here. Here in my social media contacts and my email. Thank you.
Thank you, Débora. Thank you all. I think all of you listening have now got a good overview of what we've been up to in the last years on our different or in our different research activities regarding physiotherapy and headache. You can now use the question and answer option to ask questions to all of us. I think you, Henrik, will moderate and select questions who are best suited for one of us. And while you are still thinking about what to ask and how to phrase it, if you want to be part of this community and if you want to be in an email distribution or if you want to hear from us when we're doing any activities, you can write your email address into the chat. We will keep the chat and turn this into a list of people we will include in our communication. I think this is the only option at the moment to stay in contact with you if you are not actively contacting us. Our contacts are easy to find. You'll find us on the IHS website. If you look at the Special Interest Group button, then you'll find the Physiotherapy Group, and I think at least my email address should be there. And we can help you if you've got any questions through this channel too. Okay, there's email addresses popping in. There's a couple of question and answer questions.
I think the first one's for me. Actually, I think they're both for me. So you can see the first question from Marcus on RCTs and selection criteria. Yeah, Marcus, I do recommend that you've got to use the symptomatic criteria as well for cervicogenic headache. But I think you do have to, the inclusion criteria will be that they have got restricted range of movement, that you do find it could be either the flexion rotation test or the extension rotation test. So, for example, if it's not a C1-2 headache, the flexion rotation test should be okay. Whereas if it's a C2-3 headache, you're more likely to find that the extension rotation test is the one that's limited. So it is to do active movements, our special diagnostic movement tests, the manual examination, and also look for muscle dysfunction. And if you've got that pattern together with their symptomatic criteria, you have got some assurance that it is a cervicogenic headache. But I mean, as you've mentioned there, and as Zhiqi and Débora, well, everybody has said that the migraines can have musculoskeletal signs. So that's where you've got to have the symptomatic criteria, the temporal relationship of the headache with a neck condition, etc. You've got to have those criteria as well as the physical criteria. I hope that answers it, Marcus. From Linda, the article is probably not an open access, but if you email me, I'll accidentally send it to you. Okay, third one.
It's Renee who is asking about tension type headache. And yes, I know this is really terrible. No, none of us has done lots of research on tension type headache yet. But Renee, it doesn't matter. It doesn't mean that we're not interested in it. It just happened to be that way. And we're very happy to include you and all those of you out there interested in tension type headaches as well. So don't feel as if we're leaving you out.
No, Zhiqi, yeah.
Yeah, I was just going to say, Gwen, that we have a PhD candidate right now that we're working with who's actually looking at tension type headaches. So we're definitely very interested. We'll continue our research down that track too, for sure.
Oh, that's an interesting question. What has been the level of support from neurologists for your work? I think, Débora, you've made some good experiences, right?
Yes, I have. I have a very good and specialized support. We integrated a team with doctors and residents in fellowships in neurology, and my students work together in the same place, in the same room, in the same outpatient clinic.
Yeah, I think the difference is I've shared lots of offices with neurologists, and as soon as they get to know us, I think it works really, really well. It's just that initial, oh dear, there's physiotherapists within my field, threatening behavior. As soon as that has dissolved, it's fine.
This is to Débora. In answer, I'll have a go at that one, if that's okay, Kerstin. To Débora, I think you're 100% right. We have got to get a common language and common definitions of what we use. Completely agree with that. And I mean, that can be one of our tasks, and it's not a difficult task to sort of do an index of language that we can all start to get a common language.
I think people cannot see the question, so we probably have to say what Débora was asking.
Well, basically, was the thing that a generic term like manual therapy can include anything, basically. And so we're to better define what we mean, for example, by manual therapy. And then Sam asks a similar question, how we're defining physiotherapy interventions. This is one of my pet things, actually. Physiotherapy is a profession. And so we shouldn't say that we treated them with physiotherapy. I mean, we don't treat them with physiotherapy. As physiotherapists, we use certain modalities. And I think that when we are trying to explain to people what we're doing is, for example, you would say that I am using needling, neuromodulation and manual therapies to get pain relief and exercise for their rehabilitation. And certainly the multimodal care is most optimal care. I think we've shown that. Débora, the next one is for you.
What is the question for me?
The question is whether you have said that during the CCFT, the stabilizer test, there's a greater activity of extensors.
Yes, this is a work that we measure the activity from the flexor and extension during the realization of the CCFT test. And when we asked the patients do the test, we saw more activity in these tensors. And we saw that the patients with migraine, especially for chronic migraine, migraine was different from controls, but when patients have more crisis of migraine, the activity of these tensors is increased during the activity with low task, doing the craniocervical flexion test. And we saw that the patients with migraine has a worse performance in these muscles.
Can I add another comment there? I think part of that is possibly not so much due to, well, I think it's possible that the extensor activity was a reflection of the whole sensitivity of the migraine group.
Maybe.
And yeah, because theoretically, in a non-sensitized patient, you'll get more reciprocal relaxation theoretically. If you're contracting the flexors, you'll relax the extensors. So I think a lot of that shows you the sensitivity of a lot of the migraine patients.
Yes, but when we expected that the patients present more activity in the flexions, especially in the sternocleidomastoid. And when we did the test, they present more activity in these tensors, showing to us that the patients with migraine has a imbalance or incoordination in these muscles.
Yep, could be. Okay.
There's some people who are writing, can you write your questions into the Q&A, please, and not in the chat, because it's very confusing to find those questions amongst all those emails. Okay, what else have we got? Recognition by a neurologist. Zhiqi, have you got an answer to how we can be better recognized and respected by neurologists?
I think you kind of touched on that just now, Kerstin, where you talked about communication and letting them get to know us better. I think that's the main thing, because Gwen and I have had experiences where neurologists who didn't know us and had previous experiences where the patients have come to them having been aggravated by physiotherapists. They view us with a different eye, and it's only through good communication and really understanding what we are doing that we can have a better relationship, I think.
Can you repeat that last sentence, Zhiqi? It was a little bit distorted.
I think she's
to better relationships.
Yeah, I think that's really important. And also, I think we are being taken more serious if we provide evidence and if we stick to evidence-based practice rather than doing things that are considered exotic by other health professions. And these sort of voodoo treatments will not be respected, I think. And that does happen a lot, at least in Germany. I don't know about all the other countries, but... So I think being a serious profession means that we have to have serious, explainable and evidence-based approaches. And some of the evidence we have to still to provide. Yeah, sorry. Gwen.
Yeah, no, but I think being a special group within the International Headache Society, I mean, hopefully that's a way that we foster communication and collaboration. That should be one of our greatest aims, I think.
In my experience, if you have a time, in my experience, when I arrive in this hospital, no one's physical therapy is in headache here. And we starting growing together, studying together. and especially presenting papers together, discussing in the clinical meeting together. And when the doctors realize that we know what we saying and what were and the questions emerging. And my first study about the sensitization, it was idealized post this discussion, when we discussion the sensitization, and we have the idea to check if this sensitization is lower or not. And we did the pressure brain threshold, our first study. And when doctors will see that there is evidence, we have contribution to do in the evaluation of the patients, they tend to agree and to accept our presence. It was my experience in Brazil.
Yeah. Then Nacho is saying that in Madrid, he's got 2 postgraduate courses, a master and a postgraduate course, and would like to know whether we have standards for the standards for postgraduate degree of research, standards for requirements that are already defined in teaching, I presume. Have we got anything that we can provide him with? Any standards, curricula?
I think that's one of our aims as far as headache is concerned, is to establish what educational standards that we'd advise.
Okay, Nacho, I think you'll have to do the research with us, and then we hopefully get there soon.
I can maybe also add to that in the that in the Education Committee we're working on revising a core curriculum, and I think it would be excellent to work together with the Physiotherapy Special Interest Group in the physiotherapy aspects that you could contribute to developing and revising the core curriculum, and that might give some tools that I asked for.
So keep in touch, Nacho. Then there's the topic of TMD. So jaw joint dysfunction. I think the chat has been full of questions about this, but not the Q&A. But here's a question from Jordi. And I think, has anybody looked of you looked into TMD dysfunction? I think you did some, Débora. You presented one slide on TMD. I mean, there's certainly lots of overlap. I think more with tension type headache than with migraine. If there is obvious signs of jaw or muscle dysfunction within that area, then treat it. There might be interaction. It's not very well researched, not as well as you're claiming in the chat, but there's some research out there talking about a connection between not only through the trigeminal-cervical nucleus, there's actually a second pathway where the dura mater is connected to extracranial muscles, which is through the fissures of our cranium, and that is very well researched by a group in Erlangen in animal studies. So there is a connection there. It's actually vice versa. So if the dura gets inflamed during a migraine attack, that will increase muscle tension. So sometimes this is mistaken as a jaw dysfunction, and it's actually just a symptom of a migraine. But if there's other obvious signs, then I would treat them. In our clinic, 99% of the migraine patients do have braces. If I ask them, do you wear them and do they help? They always say no. So this is my experience, but I cannot contribute anything evidence-based.
Kerstin, when I begin our work here, the patients with headache, a lot of patients have pain in the face. And I said to the doctor, the first doctor was Dr. Speciali. I said to him, can I assess the temporomandibular area in these patients? And he said yes. And we did our first work together, checking if patients with migraine has temporomandibular disorders. We assessed using the special assessment, and we saw there is sometimes it was a real temporomandibular disorder. Sometimes, like you said, is a product of sensitization of migraine. But it doesn't matter. The patient has pain, and we need to contribute in this treatment.
And there's the next question. In general, what type of treatment are you offering migraine patients? Maybe, Zhiqi, do you want to respond to this one?
So from our perspective, our clinic does assessment to see if there's anything going on in the neck, whether they have true musculoskeletal dysfunction of the neck. But also we look at the other contributing factors, and education, like what Kerstin mentioned before, is a very big part of it. Trying to put the big picture together for them to see how, identification of triggers, lifestyle factors, and how pharmacological interventions might be, integrated with what we do and what they do in self-management. So a combination of manual therapy, exercises, as indicated by what we find in the neck, but also a lot of other non-neck related interventions. Kerstin, Débora, Gwen, anything you want to add to that?
No, same. If there's anything treatable, dysfunction-wise treated. If there's none, then leave it. My personal experience in the headache clinic in Hamburg, and this is what we also showed in that study on pain neuroscience education, is that there is a great desire to understand why do I have it only on one side, and why do I feel so sensitive, and why am I feeling so sick when I have my headache? So what exactly is going wrong with me? And are you sure it's not a brain tumor? So that sort of questions are very prevalent. Again, that might be a special selection in a specialized university headache clinic. So there's a lot of, what can I do apart from medication? I'm already taking so much medication. What else can I do on top of this? So providing information about lifestyle, regular sleep, regular meals, water intake, any of that sort of questions there, as they're being asked a lot, because our patients are usually treated really well medication-wise, but they're always hoping they can reduce their acute medication intake by doing exercise or doing something for the neck or doing something relaxing or any other intervention that we can offer. Oh, the next one is difficult because it's politics. Laura, I don't know where you're practicing. This will probably be very different for each country. So don't feel discouraged. Never feel discouraged. Just do it. I think from here, one of the things that we've done before is that in Germany, you need a referral for physiotherapy. So headache patients usually get a referral that says neck pain, and then we can treat them in a normal healthcare setting without private. But this will be very different in every country, I think. I don't know what else to say to that.
No, we've just got to keep building up the evidence, and then, you discuss evidence with the honorees in the hospital.
Yeah. The answer to Harris, whether there is a standardized, structured routine assessment for the upper cervical spine. Yes, I think I talked about that set of tests that has been developed in a standardized way. It'd be really nice if people use it. I know lots of people are using it already out there, and that would be really cool if we could put data together worldwide. I'm not sure how standardized we can all be without having trained together, but at least a minimum level of standardization, I think, is possible. We're just doing one study. We're doing a field study with lots of physios that we train on one day, and then we send them out there assessing migraine patients. And I'm sure they're not all doing the same thing, but we've tried to reduce it to a minimum of standardization. And I can tell you a little bit more when we've analyzed the data, how much it is possible to standardize. I think it's 150 physios or something like that, how you can standardize their assessments.
But I think we can, as one of the jobs of this group, put out a pro forma of assessment. I think that'd be an excellent job for this group. PMJs?
Tongue and hyoid mobility to migraines and cervicogenic headache. Not that I'm aware of in migraine. I don't know about cervicogenic headache.
Which one's this, Kerstin?
This is Kervin, Ian. Is there evidence on the correlation of tongue and hyoid mobility to migraines or cervicogenic headaches?
I don't know.
No. We're sorry, we don't know this. Okay, well informed.
Elena?
Mm-hmm.
I'm happy to answer Helena's.
Mm-hmm.
The original criteria of Shorstad in defining cervicogenic headache was that it was a side-locked headache. I personally think that that is a very valid criteria, and I don't think cervicogenic headache necessarily swaps sides as they do in migraine. And the reason I say that is if you just think about a musculoskeletal disorder. So, for example, if I sprain my left ankle today, I'm not going to wake up tomorrow and have my right ankle being sore, and then the next day my left ankle being sore. A musculoskeletal condition really is has a defined area. So I think, and there's something strange neurophysiologically is happening, I would suggest that the criteria that it's a unilateral side-locked headache that doesn't swap sides is a reasonably valid criterion for cervicogenic headache.
Sarah, nice to see your name. How to facilitate funding? I don't know. And if I would, then I'd probably be millionaire. But I think if we work together in this group and have more international applications, that might actually be a very strong point. So hopefully we can sell this group as a group that's worth giving money to and do something useful with it.
To answer Sam, yes, I noticed that the other day as well. If you go onto Amazon and a few of those, there's actually, I have no idea what company or who they are, but there is somebody else has started making the device. So it is.
We've got one too. I forgot the name, and we're probably not allowed to say any company names anyway. But there are other companies making them, and they're really good. Tried them.
Yeah.
Function impairment and a structural impairment. This is a difficult question, Wanda. It's not structural. So probably functional is the more correct answer. It is a way of the central nervous system to change its status of sensitivity throughout different phases. And it does this spontaneously. So this is what we know from all our central nervous system studies, that the central nervous system just changes its response to different types of stimuli by itself. And we've now got unpublished data, which is really nice, and I hope it's published soon, that people without migraine don't have that sort of swinging activity of the hypothalamus. That is a study that's been done in patients with menstrual migraine and women in the same status of their menstrual cycle, and they didn't show that those different states of hypothalamus activity. So it is something functional in your brain and probably in the hypothalamus and its connectivity with the trigeminal nuclei and all other structures involved in the migraine attack. Is Dean Watson course correct for our society? There's no yes and no. I mean, that's what's correct. There's nothing incorrect. Hello, Dean, if you're still here. And there's an urgent need for evidence-based guidelines. Yes. Oh gosh, I totally agree. So Renee is saying we urgently need evidence-based guidelines for the physical treatment of headache patients. Absolutely, it will it will make everything easier to communicate, I think. This is also one of our goals, definitely, to facilitate this. Yeah, definitely.
With Yasmin, I mean, a lot of patients do have overlapping headaches and mixed headaches. And I think, I mean, somewhere along the line, we have got to do some clinical trials where we definitely have those complex patients to actually work out, you know, how much we can do for them. But in the clinical situation, I think you've just got to explain to the patient that they've got, you know, some signs of this headache, some signs of that headache, and that you'll do a trial of treatment and see if, in fact, your treatment is helping them at all. But I think we've obviously got to do a lot more research into the mixed headaches.
Sorry, I'm just amused by some of the comments. Yeah, totally.
For the question from Yasmin, I would like to add the how is important to have a correct medical diagnostic, because when we know the patient has migraine and we can understand the facial pain.
Sorry, Débora, can I interrupt? It's because the audience cannot see the question, so maybe can you read it up so everybody understands the answer to it? That would be great, thanks.
Yasmin, our question said, a lot of patients have overlapping headache conditions. That is a big challenge in clinical practice. Sometimes the evidence show isolated condition or the diagnosis too is not based on ICD-10 and we need to follow all the time the ICD-10, Yasmin. And she asked, any suggestion on how the clinicians can work on that? Or how the researcher can address that in their work? And I explained that it's important we have the correct medical diagnosis. Because when you don't have diagnosis, as a physiotherapist, we're looking for pain in face and neck and head, and we need to have what the patients have. What is the medical diagnosis for his headache, their headache? And with the diagnosis, we can explore better the other symptoms and signals.
Yeah, Marcus is asking whether we can provide screening tools, and the one that he's suggesting is the headache screening questionnaire, which has been done by Hedwig van der Meer and translated by you, Marcus, and your group into German at least. I'm not sure in which language it is available, certainly in English, Dutch, and German. And I'm not sure how much we can put onto that website, but it would be really nice to have some resources that are useful to provide on website, at least as a link maybe. What this questionnaire does, for those of you who don't know it, you sort of tick all the items that are listed in the classification, and then the output will be to what likelihood you've either got migraine or tension type headache. So it can be very useful if you're not that experienced in the use of the classification system, or if you want to save time and just give it to patients to fill out at home. It'll be a little bit quicker. There's also, I think, a digital version that Hedwig looked at some stage, but I'm not sure whether that's open access. Rosie, maybe a quick answer to Rosie, who's asking whether we are only looking at the neck or also at the thoracic spine. And yes, that battery of tests that I was talking about includes a thoracic screening, which is just a quick check of active and passive movements. And if you find anything there, obviously a full assessment of the thoracic spine is definitely recommended. And yes, I have found very stiff thoracic spines, especially in patients with tension type headache, but that's clinically and not in research.
Elizabeth, yes, we're certainly open to collaborating with osteopaths.
Yeah, or anybody who's willing to cooperate with us.
Yeah.
Oh, the cervical spine framework for vascular diseases, so screening for vascular disease in patients with neck and head pain. That's, I think, well implemented as far as I know. At least I'm teaching it, and nobody's too surprised. Has it helped to build trust between physiotherapists and headache specialist doctors? This is a question I cannot answer.
Wrong, Maria.
Henrik, were you saying anything? Or?
No.
Oh, so sorry, I forgot to mute. There was something. Okay. So sorry, ignore me.
Maybe move on to Amanda.
I think with Amanda, that's what we'll explore in the coming months and years.
Yeah, adherence, compliance. I prefer the word adherence because it implies that patients are actually willing to do something because they've understood why it is important, while compliance sounds more like I do what the doctor says because he's the person who is upper in the hierarchy. But so adherence is a difficult topic, but I think, yes, things to explore. And the last question. Yes. Gwen?
Yeah, I'll answer that. That's from Marty. Are you looking at shoulder and axioscapular muscles? Yes, that's a very important part of the routine examination of the neck area. I think that's it.
So I think we've answered all the questions. Maybe two last words. One is that if you feel inspired to become a member of the International Headache Society, which actually gives you the conference a lot cheaper. So if you think you want to join us in Sao Paulo, you get it a lot cheaper as an IHS member. And the IHS is giving physiotherapists as a reduced rate. So you will pay 55 British pounds if you check the box standard membership and then choose the junior nurse allied member. So that's the one thing that I was going to tell you. I've heard we've already doubled membership since this group existed. So that's really nice to see. And really, really important is to hopefully see a lot of you in person. I'm definitely excited to go to Brazil. I've never been, and it's probably going to be my one and only visit too because it's a long trip. But really excited to see your beautiful home, Débora, at the IHC. in Sao Paulo, where there will be a meeting of this group. We will announce it on the website and hopefully see lots of you in person. That's all I've got to say. Any last words from anybody? Thank you for coming. Thank you for attending. Thank you for giving us your time.
And I'd also like to say thank you so much to all of you for great presentations. And there have been so many questions, and you're excellent in answering it. This webinar is being recorded, and we'll create a version that will be available on the International Headache Society's webpage. So I really look forward to your future work and growth. So thank you so much for doing this.